welcome to GP Notebook TV. My name is Dr. David Miller-Jones and I'm going to talk about venous thromboembolic disease, diagnosis and management in relation to the latest NICE guidelines published in March 2020, the NG158. The guideline covers the diagnosis and management of venous thromboembolic disease. It aims to ensure a rapid diagnosis and early management of these patients. If we contact a patient and we are concerned about deep venous thrombosis, we should actually examine them as well as look at their past medical history, looking for signs of DVT or swollen, painful leg, and look at their underlying risk factors. The NICE guideline actually suggests we should do a 2-level DVT well score. This offers a scoring system pertaining to risk, and it looks at risks such as active cancer treatment that's been ongoing or has been present in the past 6 months. If there's been a degree of paralysis or lower limb immobilization, such as a plaster cast. If the patient has been bedridden for 3 days or more, or recently undergone some form of major surgery, either a general or local anaesthetic. Examine the patient for localized tenderness along the distribution of the deep venous system, and look and see whether it is the entire leg that is swollen. If the calf swelling is greater than 3 centimeters compared to the unaffected side, this actually does suggest an increased risk. And also assess for pitting edema being confined to the affected leg. Look for collateral superficial veins, but ensure that these are not varicose veins. Also look at past medical history. Has the patient had previous deep vein thrombosis that would put them at increased risk? If a patient has a DVT well score of 2 or more points, they should be offered ultrasound scan of the deep venous system within 4 hours. If this is not possible, they should be given a D-dimer test, but also anticoagulation started. If the D-dimer test is positive, and this is followed by a negative venous scan, then a repeat scan should be followed up 6 to 8 days later. Now, patients with pulmonary embolism sometimes present typically and sometimes atypically. Classically, patients have chest pain, symptoms of shortness of breath, or even hemoptysis. They should be examined and assessed medically. But also, if available, urgent chest x-ray should be undertaken to exclude other underlying alternative diagnoses. The pulmonary embolism rule-out criteria may be found to be useful in primary care to look at patients who are possibly at increased risk of having a pulmonary embolus. These are patients who are aged over 50, have a heart rate greater than 100, and oxygen saturations less than 95%. If they have unilateral leg swelling, certainly a history of hemoptysis. If patients have undergone some form of surgery or recent trauma, if they have had a prior history of pulmonary embolus or deep venous thrombosis, and also if they are on hormonal treatment. The NICE criteria suggests that we should refer patients who we deem at high risk, and they will have a 2-level pulmonary embolus well score. The 2-level pulmonary embolus well score once again looks at clinical signs and symptoms of DVT. Is there an alternative diagnosis less likely than pulmonary embolus? Patient's clinical criteria of a heart rate greater than 100. If they've been immobilized for more than 3 days or undergone some form of major surgery in the preceding 4 weeks. whether they've had previous history of deep vein thrombosis or pulmonary embolus, and whether they have had an episode of hemoptysis. If patients have underlying malignancy, this also causes increased concern of underlying pulmonary emboli. Pulmonary embolism is likely if the Wells score is greater than 4 points. These patients should be offered referral for radiological imaging, normally a VQ scan. If radiological imaging is not readily available, anticoagulation should be started. If the Wells score is less than 4, a D-dimer test should be undertaken. And if positive, radiological imaging then should be followed. Anticoagulation treatment for confirmed DVT or pulmonary embolus should be for a minimum of 3 months if it is deemed a provoked and the provoking episode has passed. If patients have got underlying malignancy, the current recommendation is 3 to 6 months. After 3 to 6 months, one should consider stopping the anticoagulation as long as risks have improved. In patients who have an unprovoked DVT or pulmonary embolus, one should consider the risks and benefits of anticoagulation. The Has-Bled score is normally used, and a Has-Bled score of 4 or more suggests an increased risk of bleed. Starting any form of anticoagulation, patients should be counselled. They should be given the right education and also identification leaflets to ensure that if they are involved in any accident, hospitalisation or seen by another medic, it will be clear that they are anticoagulated. Before starting the therapies, routine bloods should be undertaken to look for clotting, liver function and for blood count. Thank you for your attention.